Hello guys, in this lecture we will be discussing about the Bitewing radiographs and their interpretation. Why we call it Bitewing radiograph? This radiograph gets its name from the tab or the wings that the patient bites on to hold the film in place if we are talking about the classical method of taking the X-ray. The bitewing film is used for the detection of interproximal caries and the condition of the alveolar bone. This film shows the crowns of both the maxillary as well as the mandibular teeth, and a portion of roots and the supporting structures are also visible. A premolar film and molar film are normally taken on each side for a total of 4 posterior bitewing films in an adult person who is healthy and who has no any developmental issues. Head position while exposing the bitewing radiograph. So the head position is like that. It is positioned with the maxillary arch parallel to the floor of the mid-sagittal plane and to the floor, and the mid-sagittal plane is perpendicular to the floor like this. Maxillary arch is parallel to the floor and mid-sagittal plane is perpendicular to the floor. So this is a definite requirement if you are using bitewing tabs to hold the film in position, like the classical method of taking the X-ray. But if you are using the Rin bitewing instrument, this one, then it is not important. Bitewing technique film position. The premolar bitewing film is approximately centered on the second premolar, and the front edge of the film should be at least in the middle of the canine so that you are not going to miss the mesial portion of the premolars. The molar film is centered on the second molar if the third molars are present. If not, then in the center of the second and first molar. The long axis of the film is horizontal. Long axis is like this. Vertical angulation, if you are using tabs, means the classical method of taking the X-ray. When the film is positioned in the mouth, the upper portion of the film is angled approximately plus 20 degrees as it contacts the palate. In the middle, the film is upright, that is 0-degree angle. The average between these two angles is 10 degrees. This 10 degrees is the vertical angulation which we select when we using bitewing tabs. So the central X-ray is at the beam is at plus 10 degrees when we are taking the bitewing X-ray. Positioning the patient's head. Make sure that the maxillary arch is parallel to the floor and the mid-sagittal plane is perpendicular to the floor before aligning the tube head. Vertical angulation with the Rin instrument. Well, if you are using the Rin bitewing instrument, then align the PID with the ring. This will automatically align the X-ray beam with the correct vertical angulation, no matter how the head is positioned. No matter patient is in supine position or upright position, it doesn't matter. You just have to align the X-ray machine. Horizontal angulation with tabs. The horizontal angulation is adjusted so that a line connecting the front and back edge of the PID is parallel with a line connecting the buccal surfaces of the premolars and molars, like this. The X-rays will then pass straight through the contact areas between the teeth. The front edge of the PID should be 1/4 inch anterior to the front edge of the film to keep the beam centered on the film. If it will be at an angle, overlapping will occur. I will explain that to you how it occurs. This is how we take, and then there won't be any overlapping of the contact area. Horizontal angulation with the RIN instrument. When using the RIN bitewing instrument, align the PID with the ring. This will automatically align the X-ray beam with the correct horizontal angulation, assuming the film was positioned properly in the mouth. Horizontal angulation with RIN instrument we are discussing, the film should be kept equidistant from the teeth in an anteroposterior direction like this. Equidistant. The film should be positioned in this manner for both the premolar and molar radiographs. This will avoid any overlapping of the contact area. Here we can see if there is difference in the shape of the arches, like U-shaped arch, that's how we take the X-ray. For the V-shaped arch, and if it is a squarish arch, then we take two X-rays, two different image receptor and X-ray tube head position are required to maintain the ideal geometry. Missing teeth in the field of X-ray, like say for instance, few teeth or at least one molar tooth is missing. So what should we do? Where teeth are missing, it is often necessary to use a cotton roll to support the tab or instrument. Position the film in the mouth and then slide the cotton roll into the edentulous area like this. Make sure the cotton roll does not rest on top of the occlusal surface of the teeth which are present. Otherwise, there will be a gap between these. In the top film here, the cotton roll was not used and the tab and film dropped down into the edentulous area. Hence, we are having the tipping type of image. Here the cotton roll is used and we can get very nice image. If the bitewing film is required to be taken on a patient who is completely edentulous in one of the arches, a complete denture of that arch may be left in the mouth to help support the bitewing tab or the bitewing instrument. Like over here, patient is having complete denture in the upper arch, so that denture was left and the bitewing X-ray is taken. Vertical bitewings. Here we will be taking the bitewing X-ray in such a way that the long axis would be along the long axis of the teeth, not horizontal. Like previously we were taking it when keeping it horizontal. Now we are keeping it vertical. Here this is the horizontal, this is the vertical. That's why I kept both the X-rays over here to show you the difference. Why we require it? In case if there is too much resorption of the interdental bone or too much involvement of the periodontal tissue in case of severe periodontitis, and we have to check the level of the bone, then we go for the long, like this vertical bitewing X-ray, keeping the film in the long axis in such a way that the long axis is going to be along the long axis of the teeth. Here we can see an adult horizontal bitewing X-ray. And over here we can see a child horizontal bitewing X-ray. Keep in mind that when you are taking the pediatric bitewing X-ray, the distal surface of the last erupted tooth in the oral cavity or in that side of the arch, upper and lower both arches, it should be covered. Remember that. No matter if there is no any tooth distal to it, but still we will be taking the X-ray of the distal surface as well. Well, here we have shown you the vertical bitewings. When you are taking vertical bitewings, they will be covering lesser area. So where you were using just one film to take the horizontal bitewing, for the vertical bitewings, you will be using two films. I have already mentioned that for the pediatric bitewing X-ray, always take the X-ray in such a way, like over here, it is the first molar, lower, it is the permanent molar. This is the first permanent molar, upper. then the deciduous second molars and deciduous first molars. Whatever the tooth which is the last one, we have to take the X-ray in such a way that it should be covering the distal surface of that last tooth in the arch, both like upper and lower on the same side. Here we can see upper second deciduous molar, and we can see the deciduous first molar, lower deciduous second molar, lower deciduous first molar. We can easily see the caries over here, and the first permanent molar is still in the developing stage. It is not yet erupted. Now, how we interpret the bitewing radiograph? Criteria for the ideal bitewing radiograph. The image should have acceptable definition with no distortion or blurring of the image, like this. The image should include from the mesial surface of the first premolar to the distal surface of the second molar. If the third molars are erupted, then 7-8 contact should be included as well. Means the second molar and third molar contact should be included as well. The occlusal plane bite platform should be in the middle of the image so that the crowns and coronal parts of the roots of the maxillary teeth are shown in the upper half of the image, and the crowns and coronal parts of the roots of the mandibular teeth are shown in the lower half of the image, and the buccal and lingual cusps should be superimposed. For dental caries and for the restorations. Criteria for the ideal bitewing radiograph for caries and restorations interpretation is the maxillary and mandibular alveolar crest should be shown, like here. There should be no overlap of the approximal surfaces of the teeth. Here it is not good, as well as over here. We can see the overlap. The desired density and contrast for film captured images will depend on the clinical reasons for taking the radiograph. For example, to assess caries and restoration, films should be well exposed and show good contrast to allow differentiation between enamel and dentin and to allow the enamel-dentin junction to be seen. How we interpret the dental caries. Here we can see this diagrammatic or the schematic diagram. Enamel caries less than halfway through the enamel here. Less than that would be considered as incipient. It is also to some extent covers the definition of incipient. Then the enamel caries penetrated over halfway through the enamel. No matter it is just the initiation of the caries or it is halfway or is approaching the dentino-enamel junction like over here, the enamel caries on the smooth surfaces or in the proximal areas, they will appear in the shape of a triangle. A triangle whose base will be towards the external surface or outer surface, and the apex will be towards the dentino-enamel junction. When the caries, they are going to penetrate through the dentino-enamel junction, they will first progress along the dentino-enamel junction, and then they acquire the shape of another triangle whose base will be towards the dentino-enamel junction and apex will be towards the pulp. The occlusal caries, they also acquire the shape of the triangle when they start in the enamel in the pits and fissure area, but the apex will be towards the occlusal surface or towards the outer surface. And base will be towards the dentino-enamel junction. But when they cross the dentino-enamel junction, firstly, the caries, they progress along the dentino-enamel junction, and then they acquire the shape of another triangle whose base will be towards the dentino-enamel junction and apex will be towards the pulp. Well, when you receive the X-ray, always try to see, or when you expose the X-ray, try to see the enamel caries or the proximal caries, no matter enamel or dentin, I must say, in this area. which is shown with this rectangle over here, above the cemento-enamel junction. Below the cemento-enamel junction, chances would be you will be seeing, in most of the cases, the cervical burnout, or if the caries are present, then they will be the cemental caries. Here we can see various carious lesions. When huge caries are present, at times we tend to miss the incipient caries. So scan the X-ray with your eyes properly so that you are not going to miss any single caries. Here we can see rampant caries, or what we call the bombarded mouth. Too many caries we can see over here. These are the root caries. And for root caries, remember one thing, that there should be some some portion of the cementum or root is going to be exposed in the oral cavity, means the supporting bone is going to be resolved. Root caries here we can see, and these projections over here, or these spikes type of the things, these over here, this ring over here, it is all calculus. Recurrent caries. In case of a class 2 filling, the recurrent caries usually they appear in the proximal box and most commonly in the distolingual area of the proximal box, most commonly, but can occur anywhere. On this X-ray, we can see a lot many things, like we can see the occlusal caries, which are quite huge. Then we can see the overlapping with the mag bands over here. Then we can see the proximal caries in enamel. Then we can see cervical burnout as well. What is this cervical burnout? It is also known as adumbration. So it appears between the cemento-enamel junction and the alveolar crest. And if you will be looking closely, you will see that the edge of the root will be present. Whereas in cemental caries, the edge of the root will be missing. Why it occurs? The bone is quite radio opaque, and the enamel is also of the crown is also quite radio opaque. And it is a three-dimensional object, and the X-rays, they are passing through it, which will be casting the image on the receptor. At times they miss these edges. They are not fully exposed. That is why we get that radiolucency in that area. How we can use these bitewing X-rays in periodontal disease. Criteria for the ideal bitewing radiograph for periodontal condition interpretation. To assess the periodontal status, films should be underexposed, like over here, underexposed, to avoid burnout of the thin alveolar crestal bone. The image should be free of coning off or cone cutting. I will show you what cone cutting is, or coning off, and other film handling errors. The image should be comparable with previous bitewing images, both geometrically and in density and contrast. How we can use these radiographs in periodontology? Well, we can see for the amount of bone present or the amount of bone lost, condition of the alveolar crest, bone loss in furcation areas, width of the periodontal ligament, local factors like calculus, overhanging restorations. Then we can also interpret the crown root ratio, but it cannot be assessed on a bitewing radiograph. For that, you will be requiring the periapical X-ray taken in the paralleling technique. Limitations of the radiographs. No indication of morphology of bony defects, no indication of successful management, no indication of hard-soft tissue relationship, that is depth of the pockets. This is the normal alveolar crest. It is almost 1 to 1.5 millimeter, and other authors they say that it is almost 1.5 to 2 millimeter apical to the imaginary line joining the two adjacent cemento-enamel junctions. And it should be smooth, no any erosion is visible, and should be in continuation with the lamina dura without any blunting in that area, and should be having almost same type of radio opacity. These are the lines, and here we can see that. Though on this radiograph we can see some calculus deposits, but still normal bone level is present. Another case. Evidence of early periodontitis. There will be localized erosion of the crest of bone, blunting of the crest in the anterior teeth, and loss of sharp angle between lamina dura and the crest. There will be widening of the periodontal ligament near the crest as well. Local factors like calculus, overhanging restorations, poor restoration contours can also be seen. Calculus can also be seen on the X-rays. Bone loss can also be seen on the X-ray. So as I told you about the two adjacent cemento-enamel junction, we assume a line joining that, and then we compare whether the bone loss is there or not, and if it is parallel to that line or it is at an angulation to that line. Like if it is parallel to that line, we will call it horizontal bone loss. And if it is at an angulation to that line, then we will call it vertical bone loss or angular bone loss. This is the horizontal bone loss. And here we can see the angular or vertical bone loss. Errors in the technique when we are taking the X-ray using the Bitewing technique. Overlapping of the contacts. So what happens if the horizontal angulation is not aligned correctly, so that the X-rays they pass through the teeth contacts at an angle, the contact areas will be overlapped. Overlap is the superimposition of the part of one tooth with the part of the adjacent tooth. And why it happens? Over here we can see the angulation of the beam. And this is the contact, like one part of the tooth, this is the part of the other tooth, they appear overlapping each other. Improper film placement. Improper film placement is a common error seen in the Bitewing technique. In the premolar film, this one, it is placed in such a way that mesial portion of the first premolar is missing. And here it is placed in such a way that the distal portion of the third molar is missing. Improper film placement. If the top edge of the film it comes in contact with the palatal gingival edge, the film may be pushed down into the floor of the mouth as the patient closes their mouth. This results in a bitewing that looks more like a periapical film like this one. This is more likely to happen when you are using the tabs instead of the RIN instrument. Cone cutting. This is cone cutting I was just mentioning earlier. If you are not focusing properly and you are not placing the central beam in such a way that it would be exposing the whole film, then this white area or unexposed area will be there, which we call cone cutting. So over here, we are done with our this X-ray, and hopefully it is going to help you in identifying the caries or carious lesions on the Bitewing X-ray for your OSCE exam. It will also help you in identifying the type of bone loss over there or furcation involvement. And it will also help you if somebody will ask you about the errors on the Bitewing radiograph, so you would be able to identify those errors. Thank you very much. Soon I will come back with more videos for you. and they are going to help you in your OSCE exam, as for that exam which you are appearing in the Irish Dental Council exam. See you guys then soon. Good night.